بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will discuss one of the most important topics in chest imaging, which is about the blunt chest trauma. As you all know, the chest injuries are considered the most common, the third most common next to head injuries and extremities. 70% of the victims of blunt trauma suffer a thoracic injury, and the thoracic injury accounts for about 25% of deaths due to trauma. More than two-thirds of the cases caused by motor vehicle accidents, and the remaining cases result from falls or blows from blunt objects. The current imaging for evaluation of the chest trauma include the chest X-ray, which is considered one of the screening tools for initial evaluation of the possible chest injuries. But CT is considered the most highly sensitive technique in evaluation of the actual results of chest trauma. Rarely we may need the help of an angiogram whenever there is a doubt about the integrity of the great vessels. Ultrasound is one of the helpful rapid tools which can detect the possibility of bleeding in the pleural space and also evaluate the integrity of the abdominal organs. These are the possible results of the chest trauma. They include pulmonary contusion, laceration, lung herniation, lung torsion, pneumothorax, hemothorax, bronchial injuries, pneumomediastinum, hemomediastinum, aortic and esophageal injuries, cardiac injuries, diaphragmatic rupture, and finally the chest wall fractures. As a general rule, if a patient had a lung opacity after trauma, this is considered most likely to be a pulmonary contusion, while if there is a pleural collection, we consider it as hemothorax. The pulmonary contusions are considered the most common injury, which is seen in about 75% of the patients, and this results from leakage of fluid and RBCs into the alveoli. Contusion at X-rays may be delayed up to 6 hours, but the contusion is immediately seen by CT after trauma. Contusions are more or less areas of pulmonary consolidation. They may show air bronchogram, but they do not respect the fissures as pneumonia, and also they are more centrally located than the peripheral location of pneumonia. Contusions change rapidly in appearance when compared to pneumonia or aspiration pneumonia, which are also considered in the course of chest trauma. And this is a case of post-traumatic chest injury where you see an opacity in the right lung, and this opacity has changed somewhat in the follow-up chest X-ray done after the initial few hours. Then pulmonary contusion is just an opacity in the lung. It may show air bronchogram, and it represents an area of consolidation following trauma. And contusion may be single or multiple, may be unilateral or bilateral, may be small or massive, as you can see here. And this is the case of chest barotrauma due to severe air bag injury. Then you see a clavicular fracture, and you see almost total consolidation of the left lung with some air bronchogram, and also you can see some subcutaneous emphysema. Pulmonary contusions are seen immediately, as I have mentioned. In CT, they start resolution within 1 to 2 days, and they are completely resolved within up to 10 days. Then the contusion is considered when you see an opacity following chest injury. Also, in the differential diagnosis includes the aspiration pneumonia and the fat embolism. This is a bullet injury of the chest, and you can see the bullet track, and you see the bullet itself. And this is a linear contusion in the lung along the course of the bullet. Also, you can see subcutaneous air in the chest wall. And here you can see after trauma, multiple pulmonary opacities definitely represent contusions. And if you look carefully, and you can see that there is also a clavicular fracture. In the CT scan, you see multiple patchy opacities scattered in both lung fields, being more extensive on the right side, representing pulmonary contusions. The second injury is pulmonary laceration, and this is due to disruption of the lung parenchyma, which will result in what looks like a cavitary lesion. And this laceration may take weeks to months to reach complete resolution. Laceration may be complicated by superimposed infection or abscess formation or bronchopleural fistula. And this is a classic appearance of a pulmonary laceration with internal air fluid level and a nearby pulmonary contusion showing patchy opacity with some air bronchogram inside. Pulmonary lacerations form a cavity due to the elastic recoil of the lung tissue. Then the cavity may be secondary infected or may communicate with the pleura, resulting in a bronchopleural fistula. This is also another example of pulmonary laceration showing a linear, let us say, cavitation in the lung surrounded by an area of opacities. And in this post-traumatic case, you can see the combination of pneumothorax, air in the pleural cavity, pulmonary contusions, multiple opacities in the lung, showing air bronchogram, as well as a small area of focal laceration. You can see also here some contusion. Then this is a CT scan of a patient after chest trauma where he developed bilateral pneumothorax and an intercostal tube has been inserted on the left side. There is extensive pulmonary contusion on the left side, pulmonary laceration on the right side, air within the mediastinum surrounding the cardiac shadow, denoting pneumomediastinum, and this arrow points to the presence of rib fractures, and there is also surgical emphysema in the chest wall. And pulmonary laceration may be associated with pulmonary contusion, of course, and here you can see opacities in the lung representing pulmonary contusions, cavities in the lung representing pulmonary lacerations. The third issue is what is known as lung herniation, which is considered a rare sequence of severe chest trauma, where you can see part of the lung is herniating through the chest wall into the subcutaneous space. And this herniation of the lung can also occur at the points of weakness in the chest wall, like the site of previous chest tube insertion. And here you can see a good example of lung herniation, where the lung containing the vascular markings is seen herniating outside the confinement of the thoracic cavity into subcutaneous area. And this is a CT scan of another case with lung herniation. You see the lung herniating underneath the pectoralis major muscle. Then torsion of the lung is considered one of the very rare results of blunt trauma and is usually seen in the pediatric patients. And this torsion may result in vascular compromise of the lung, and this will lead to pulmonary infarction. This is an example. The diagnosis of torsion is, of course, is difficult, but you can consider it whenever you see some of the landmarks like abnormal distribution of the lung vessels, as you can see here, and of course, from the clinical picture of the patient. One of the predisposing factors for lung torsion is the previous lobectomy. Then, after lobectomy of one of the lungs, there is a space left in the hemisthorax at the site of the previously removed lobe. Then there is a tendency of the remaining lobe to rotate or to be torsed within the remaining cavity. And this is an example of a lung torsion in a patient presenting by severe dyspnea and fever, initially treated for pneumonia, and follow-up after 5 days showed right-sided pleural chest pain and increased shortening of the breath. And the chest X-ray, the initial one, showed an opacity in the right lung field. The follow-up X-ray showed the what looks like resolution of this opacity and the appearance of another one in the lower lung zone. And the CT scan showed that there is torsion of the lung with the major fissure displaced upward, and you can see the middle and the lower lobe bronchi going upwards, and this is an indication of lung torsion. And in this patient also, you got torsion of the lower lung lobe after uh, left lower lung lobe cancer after lobectomy, torsion of the upper lobe after lobectomy of the lower lobe. And this is one of the sequelae of lobectomy, and there is an incidence that the remaining lobe may be displaced or rotated within the thoracic cavity. Then the pleural complications may include pneumothorax and hemothorax. The pneumothorax is one of the common findings after blunt chest trauma, seen in about 40% of the cases, but the X-ray is a little bit insensitive for the detection of minor pneumothorax, but the CT scan is, of course, is extremely sensitive in this domain. And about 10 to 50% of pneumothorax may not be seen in the supine chest radiography. Also, the detection of tension pneumothorax is very important, and this is to be noted that a small pneumothorax may enlarge or increase after mechanical ventilation. Then the signs of pneumothorax in the supine radiograph include the increased translucency of the affected lung base, what is known as the deep sulcus sign, where you can see that the costophrenic angle is more deep compared to the opposite one, and the double diaphragm sign, where you can see the diaphragm, and because of the compression and the collapse of the lung, it may give you an impression that there is another diaphragm here. And this is the appearance of the pneumothorax. In the erect film, you see pneumothorax at the apex of the lung, while in the supine film, the pneumothorax will be at the costophrenic angle, resulting in what is known as the deep sulcus sign. This is an evident pneumothorax where you see the line, the pleural line, the peripheral zone is empty of vascular markings. Then you may also appreciate the presence of some deep sulcus sign. And this is also another example of pneumothorax drained by intercostal tube. The deep sulcus sign is evident and the underlying lung is collapsed. In this example, you see the deep sulcus sign, but you cannot appreciate the presence of pneumothorax. And this is one of the important signs to predict the presence of pneumothorax in ICU patients, where the chest radiographs are usually obtained in the supine position. And the tension pneumothorax means that the collection of air in the pleural cavity has resulted in increased intrapleural pressure above the atmospheric pressure. And this will result in compression of the heart and mediastinum, which are usually displaced to the opposite side, and also compression and depression of the diaphragm with consequent hyperinflation of the affected hemithorax. This is a reformatted coronal CT image of a patient following chest trauma showing tension pneumothorax with massive accumulation of air in the pleural cavity on the left side, severe depression of the diaphragm, displacement of the heart and mediastinum to the opposite side, and extensive subcutaneous surgical emphysema, as well as multiple rib fractures. And this is another example of tension pneumothorax. Then is the pneumothorax cannot be appreciated in the plain film apart from this relative deep sulcus sign, but the CT scan is uh, showing the pneumothorax clearly in on the left side. Then hemothorax means that there is accumulation of the blood in the pleural cavity, and you know that blood is different from the pleural effusion by its density. The blood is more dense than the pleural fluid, and massive hemothorax that exceeds 1 liter may result in shock and hypoperfusion. And in this case, you can see rib fractures, you can see pleural collection, which is more dense than the fluid, and you see some pulmonary contusions as well as the subcutaneous emphysema. And this is traumatic hemothorax, and there is a collection in the pleural cavity which is relatively hyperdense, and at that time, as I have mentioned in the beginning of this lecture, whenever you see a collection in the pleural cavity after trauma, consider hemothorax. And this is another example of massive hemothorax on the right side with consequent displacement of the heart to the opposite side. Another example of massive hemothorax. In the hemothorax, of course, will simulate pleural effusion in the plain chest X-ray, and you need a history of trauma in order to predict that the collection in the pleural cavity represents hemothorax. Hemothorax can be tension when there is rapid accumulation of blood in the pleural cavity, resulting in compression collapse of the lung and the shift of the mediastinum to the opposite side. At that time, you can call it tension hemothorax. In this patient, you can see rib fractures and the leakage of the injected contrast material at the site of bleeding, and also you can appreciate the amount of pleural blood compressing the underlying lung, and also there is a small pneumothorax here. Another example of pulmonary contusions and a pneumothorax and hemothorax. Then we call this pneumohemothorax, blood and air in the pleural cavity, pulmonary contusions bilaterally, surgical emphysema in the chest wall. And tracheobronchial injuries are rare, and the reported incidence is about 2% in the blunt chest trauma. And most of the injuries occur within 2 centimeters from the carinal area. The right mainstem bronchus is more vulnerable to injuries rather than the left one. Then the symptoms of tracheobronchial injuries are usually non-specific, but one of the signs, the important signs, is the persistent pneumothorax in spite of adequate chest tube placement. And also, there is what's known as the fallen lung sign, where the lung is compressed by the rapidly accumulating pneumothorax towards the mediastinum. Then this arrow points to the site of bronchial injury on the right side, with consequent development of significant pneumothorax and the former lung sign against the hilum and mediastinum. And this arrow shows the presence of air tracking in the mediastinum towards the neck, which indicates the presence of pneumomediastinum as well. This patient had a persistent pneumothorax in spite of the chest tube, and this CT scan with a coronal reformation showed that there is a tear at the carina itself, with leakage of air from this tear into the pleural cavity. There is also surgical emphysema in the chest wall. This patient had post-traumatic pneumothorax and lung contusions. And the right pneumothorax was drained by an intercostal tube, but the contusion didn't improve. And the endoscopic evaluation of the patient showed that the upper lobe bronchus is injured and is stenosed, as you can see here. This is one of the complications of a chest trauma. Then you came to the pneumomediastinum, where air is present in the mediastinum, and it can track its way into the soft tissues of the neck. And this is one of the very good helpful signs to predict the presence of pneumomediastinum. One of the signs also is the continuous diaphragm sign, which indicates the presence of air in underneath the cardiac shadow, enabling the delineation of the whole course of the diaphragm. Then this is what I mean by continuous diaphragm sign, where you are able to see the diaphragm along its whole course. And you know, because of the contact of the cardiac shadow to the diaphragm in this particular area, you cannot see the diaphragm here. But whenever air is present in the mediastinum, then you are able to see it. And here there is pneumothorax as well on the right side. If you look carefully here, and you can see the continuous diaphragm sign, where you are able to follow the diaphragmatic contour from left to right. And also, if you look carefully, then you see air tracking in the neck, and this is one of the helpful signs to predict the presence of a pneumomediastinum. If you have CT scan, it's easy to see the presence of pneumomediastinum and also the presence of minor degree of pneumothorax. One of the signs also of pneumomediastinum is what's known as the double bronchial wall sign. Since you can see the bronchus because of the air outside the bronchus due to pneumomediastinum, and air inside the bronchus, which is a normal condition. And in this patient, and you can see also the air tracking into the soft tissues of the neck, which is, in my opinion, one of the helpful signs to predict the presence of pneumothorax. Then one of the complications also is development of pneumopericardium. And you know that the pneumopericardium does not extend beyond the cardiac pedicle, while pneumomediastinum can extend through the superior mediastinum reaching up to the neck. And mediastinal hematoma is due to injuries of one of the vessels, either artery or vein, and you can see a post-traumatic soft tissue density surrounding or encasing the mediastinal vessels. And this is an example of hemomediastinum, a soft tissue mass or density surrounding the vessels, and also hemothorax with some blood in the left pleural space. The injuries of the major vessels, especially the aorta, is considered one of the serious complications of blunt chest trauma, and the majority of patients die at the site of the trauma. And the important diagnostic tool in this domain is the CT scan, and X-ray may be helpful to predict the aortic injury, but the actual appearance or the full appearance or full delineation of the site of the injury and the complications is usually reached after CT scan, especially if you inject contrast material to delineate the vessels. Then you may got mediastinal hemorrhage because of the aortic leak. You may got blood in the pleural space, usually on the left side. Then massive mediastinal or pleural hemorrhage may lead to immediate death. The most common site, the most common point of aortic injury is in this area, which is known as the aortic isthmus between the origin of the subclavian artery and the site of ligamentum arteriosum. This is the highly mobile region in the aorta and is the most vulnerable site for trauma. And the trauma may result in an intramural hematoma or intimal or medial tear with the development of pseudoaneurysm or complete rupture of the aorta with mediastinal hemorrhage. An aortic intramural hematoma occurs as a primary event in hypertensive patients due to spontaneous bleeding from the vasa vasorum into the media or penetrating arteriosclerotic ulcer, or may result from blunt chest trauma. Intramural hematoma may result in weakness of the aortic wall, then may lead to the formation of a pseudoaneurysm or even rupture of the aorta. Then, if you look here, and there is some widening of the mediastinum and the blaring of the arch of the aorta. You can also appreciate here in the root of the neck, and the CT scan showed a tear in the distal part of the aortic arch, which is surrounded by blood in the mediastinum. And also you can see pneumothorax on the right side, surgical emphysema, and pneumomediastinum. These are the grades or the types of aortic injury affecting this particular segment. Grade 1 is just an intimal tear like this. Grade 2, an intramural hematoma. Grade 3 is a false aneurysm or pseudoaneurysm, and grade 4 is rupture of the aorta. And there are some of the plain film signs which can help to predict the aortic injury. These include number one, irregularity or blurring of the aortic contour. Number two, the presence of left apical pleural cap, this area, and deviated endotracheal and nasogastric tubes, meaning that there is an accumulating mediastinal hemorrhage. Depression of the left main bronchus, which is usually compressed by the hematoma, and the presence of left hemothorax, accumulation of blood in the pleural space. Then these are the signs: hemothorax, depression of the main bronchus, left displacement of the endotracheal tube to the opposite side, flaring of the aortic cap, and the presence of a pleural cap. Then this is an aortic injury with dissecting intimal flap in the ascending aorta with periaortic hematoma and also extension into the pleural space. This is another example of aortic injury with the formation of a pseudoaneurysm as well as extensive mediastinal hematoma with pulmonary contusion as well. And this is another example of aortic injury and a formation of a pseudoaneurysm. You can see this protruding pouch from the undersurface of the aortic arch, which represents the pseudoaneurysm. And it's important to differentiate this pseudoaneurysm from the ductus diverticulum. And the history of trauma, the presence of mediastinal hematoma, and other features of trauma will help to differentiate both conditions. Esophageal rupture is rare in blunt chest trauma, and it occurs in about 1% of the cases. The esophageal injuries in general have a high morbidity and mortality. The CT findings of esophageal injury will include pneumomediastinum, mediastinitis, hydropneumothorax, and leakage of orally administered contrast material into the mediastinum or the pleural space. If the collection in the pleural cavity includes chyle, then there is a high possibility of thoracic duct injury. And this is an example where you got leakage of the orally administered contrast material into the pleural space resulted from esophageal pleural fistula. And cardiac injuries are also one of the possibilities of blunt chest trauma, and they range from contusion to frank cardiac rupture. And the patient may have abnormal ECG findings and elevated cardiac enzymes. Then the cardiac injuries usually affect the left side of the pericardium parallel to the phrenic nerve or the diaphragmatic surface of the pericardium. Injuries to the right-sided chamber are more common than the left side. The risk factors for cardiac injuries in blunt chest trauma include age above 50, the chest impact above 15 miles per hour, past history of cardiac disease, sternal fracture, which is one of the important signs, thoracic spine or rib fractures, hemodynamic instability, and marked pericardial tenderness, ecchymosis, and contusion. Then the cardiac injuries include the development of blood in the pericardium, the development of air in the pericardium, displacement of the heart due to pericardial injury, which is known as luxation, contrast extravasation into the pericardial sac or the mediastinum, and also abnormal bowel gas in the chest due to diaphragmatic tear. Then this is what we call luxation, which indicates injury of the pericardium with herniation and displacement of the cardiac shadow outside the pericardium, usually to the right side, and also they may be associated with torsion of the great vessels. And this is what we call luxation or herniation of the cardiac shadow outside the pericardium. You get pulmonary contusions, rib fractures, pneumothorax. You can see here there is some air in the left pleural cavity and also blood. You get surgical emphysema in the chest wall, and you got also pneumopericardium, as you can see here. And this is the hemopericardium due to aortic dissection. You see the dissecting intimal flap and the soft tissue density within the mediastinum representing mediastinal hematoma, and also you see a soft tissue density within the pericardium representing hemopericardium. Then diaphragmatic rupture is also one of the sequelae of trauma seen especially in young males, and the estimated incidence is about 4.5% of the cases. The left hemi diaphragm is more vulnerable to injury compared to the right side because of the presence of the liver on the right side, and most of the ruptures are longer than 10 centimeters in diameter, and if not diagnosed in the first 4 hours, it may be undiagnosed for months or even years. And the patient with diaphragmatic rupture may present by chest or abdominal pain, dyspnea or orthopnea, reduced breath sound in the lower lung field, respiratory failure, bowel sounds heard in the chest, scaphoid abdomen, peritonitis, palpation of abdominal viscera during insertion of the chest tube, and hemodynamic instability. At the plain film, the, uh, the specific findings may be seen in up to 50% of the cases, and these signs include inability to trace the normal hemidiaphragm. You cannot follow the diaphragmatic copula, intrathoracic herniation of viscous like stomach, colon, or small bowel with characteristic air content, focal constriction of the viscous at the site of tear, which is known as the collar sign. I will show it. Then, if large, the diaphragmatic rupture, if large, mass effect may cause contralateral mediastinal shift. Nasogastric tube above the diaphragm on the left side may be also considered a sign of gastric herniation and diaphragmatic rupture. Then if you look carefully here and you see, you cannot see the left diaphragmatic copula, and you see some air in the left hemithorax. And if you look at this coronal reformatted image, you can see the defect in the diaphragm with herniation of the abdominal contents through it. Then CT is more helpful in the diagnosis of the phlegmatic ruptures. It will enable to see the direct discontinuity of the diaphragm, the intrathoracic herniation of the abdominal contents, the collar sign, which is a waist-like constriction at the site of the herniation, and the dependent viscera sign, which means that there is direct contact between the viscera and the vertebrae as well as the ribs due to absence of the diaphragm. In here, you can see the edge of the diaphragm and the rest of the diaphragm is ruptured and the liver is displaced into the thoracic cavity. In this example, you can see displacement of the abdominal organs within the thoracic cavity, compression of of the related lung, and the presence of rib fractures. And this is what we call dependent visceral sign. See the stomach in direct contact to the ribs and the vertebrae. And if you look here, because of the presence of the diaphragm, there is no contact between the liver and the ribs. This is what we call the dependent visceral sign. And here is also another example. You see the viscera, the small bowel, are in direct contact to the ribs on the spine, and this is known as the dependent visceral sign. This is what we mean by collar sign. Here the arrows points to the site of diaphragmatic defect, and there is constriction of the stomach at the diaphragmatic defect representing the collar sign. And here also a color sign where you see the constriction of the stomach at the site of the diaphragmatic injury. Finally, we came to the one of the commonest injuries in the chest after trauma, which is rib fractures. And rib fractures affecting the first to the third rib are considered if there is a high energy trauma, and they are frequently associated with brachial plexus and subclavian vascular injuries. The CT, of course, is very sensitive to detect the rib fractures, especially whenever you have the 3D reformatted images obtained by the multi-detector CT. Complications of rib fractures include the presence of blood in the pleural space or air, and the presence of subcutaneous emphysema and pulmonary contusion and even laceration, of course. Then, whenever there are fractures of three or more consecutive ribs in at least two places in each rib, this is known as flail chest. And the fractures move paradoxically compared to the rest of the chest wall, and this is one of the very painful conditions and also needs surgical treatment. About 40, 30 to 40% need mechanical ventilation, and the incidence of acute respiratory distress syndrome may reach about 30% of cases. Then there should be a close monitoring of the respiratory performance, adequate analgesic therapy because of pain. Then you give oxygen and ventilation. Then you perform aggressive pulmonary toilet. And here you can see, of course, the detection of fractures by the plain film and even the axial CT images is very difficult. But whenever you have these 3D reformatted images, you can easily um, sees the site of the fractures very well. And here you can see pneumomediastinum and pneumothorax with the chest tube, surgical emphysema, and multiple rib fractures. But whenever you have these images, you can easily count and see the site of rib fractures and identify if it is a single or double fracture. In the axial images, you can see the complications, and this is one of the ways how to fix the rib fractures in another different case, and you can see here. And this is multiple rib fractures clearly identified by the 3D reformatted images associated with pulmonary contusion, minimal degrees of pneumothorax. Scapular fractures are uncommon and they represent 4% of all shoulder girdle fractures. They may be associated with pneumothorax, hemothorax, pulmonary injuries, and spinal fractures. The 3D images also are very helpful in the diagnosis of scapular fractures. Then we came to the sternal fractures, which are considered a marker of high energy trauma. And simple sternal fracture may be an isolated injury, but the fractures can be associated with other injuries, especially in the spine and the intimately related aorta. Then the sternoclavicular joints may be dislocated, and posterior dislocation may lead to injuries of the mediastinal vessels, the trachea, and even the esophagus. The sagittal reformatted images are very good for delineation of sternal fractures and their displacement. The presence of an anterior mediastinal hematoma is highly suggestive of possible injuries of the vessels. There is extensive surgical emphysema, extensive pneumomediastinum as well, and this arrow points to the presence of an associated spinal fracture, which is may be frequently seen in cases of sternal injuries and also multiple fractures of the spinous processes of the vertebrae. Thank you very much. Alhamdulillah.